the next set of disorders, including psychotic disorders as well as some developmental disorders. The first one we're going to look at is delusional disorder. This occurs when a person has one well-systemized, non-bizarre delusion without any other psychotic symptoms. So understanding delusional disorder is you kind of have to understand the difference between what a delusion is versus what a hallucination is. So a delusion is basically like a skewed version of reality. So it's basically something that can possibly be true. So these can include delusions about having a disease or being cheated on by a partner or being followed, being admired by somebody, or being poisoned by somebody, versus a hallucination, which is present in psychotic disorders such as schizophrenia, includes more things such as like hearing voices that aren't there or seeing things that aren't there. So that's kind of the difference there. So delusional disorder does not have hallucinations, just characterized by delusions. Physical exam you might be normal, other than them perhaps telling you about certain delusions that they're having. So DSM-5 criteria for diagnosis of delusional disorder includes the presence of one or more delusions for 1 month or longer, criteria of A of schizophrenia never being met, which criteria A basically of schizophrenia says more than 2 of the following, including delusions, hallucinations, thought disorders, disorganized behavior, or negative symptoms. So essentially, if somebody does have more than 2 of those things, then they have schizophrenia rather than delusional disorder. So that would be the second criteria for delusional disorder. The third is functioning is not markedly impaired, so they can still live a fairly normal life. The next one is if a mood episode occurs, it must be brief compared to the duration of the delusion. So essentially, the delusions can't be caused by the mood disorder. They have to be 2 separate things. And the last one is it cannot be attributed to a substance or medical condition. So just like a lot of the other conditions, delusional disorder cannot be a cause of perhaps a medication that they're on or another medical condition. So treatment for delusional disorder, first line includes CBT, cognitive behavioral therapy, and there's also a type of therapy called humanistic or expressive therapy that is used for delusional disorder, as well as photo voice. So those are just some other kind of key things in the treatment of delusional disorder. As for medications, atypical or typical antipsychotics can be used, mood stabilizers can be used, antidepressants, anxiolytics, and omega-3 fatty acids are a good supplement here. So the pharmacological treatment, basically, you kind of vary it based on what their major symptoms that they're having and how much it's impairing them. Another just note about delusional disorder is there's a couple different types of delusions that are talked about that you should be aware of. So these include persecutory, so that would be like the delusion that someone's out to harm them, and that is the most common. Somatic, which is a false belief about a bodily function. Erotomatic, which is the delusion that somebody is in love with them. Grandiose, which means that they have a delusion that they possess a great talent or insight, as if like they have the secret to the universe, is what I've seen on some things. They have the jealous type of delusion, which is when they believe that their spouse is being unfaithful to them. There's the religious delusion, which includes them believing they're a saint or a prophet. Or there's just mixed, meaning that there's multiple types of delusions occurring. So the next one we're going to go down to schizophreniform disorder, because this kind of follows a progression. So schizophreniform disorder is basically when a patient has psychotic symptoms and social or occupational dysfunction that persists for 1 to 6 months. So basically, when you're thinking schizophreniform versus schizophrenia, schizophreniform occurs for 1 to 6 months, whereas if this persists longer than 6 months, then it becomes schizophrenia. If it persists only a month, then it's brief psychotic disorder. So basically, when you're thinking about it, you want to think brief psychotic disorder is for the first month, schizophreniform is from months 1 to 6, and then schizophrenia is 6 months or more of these symptoms. So because they're basically the same, it's just time that differentiates them. Let's just go over the DSM-5 criteria for diagnosis of these things. So for schizophrenia in general, the criteria for diagnosis, like we said, the first one is 2 or more of the following symptoms: delusions, hallucinations, thought disorder, disorganized behavior, and negative symptoms. So some of these negative symptoms can include avolition or not wanting to do anything, anhedonia or lack of interest in things, flat affect, alogia, which means they're just not saying much, or asociality, which is just lack of engagement. Whereas positive symptoms of schizophrenia include the delusions, hallucinations, and agitation. These are important to kind of keep in mind when you're thinking of the treatment and typical versus atypical antipsychotics, because the typicals are the older ones and those only treat the positive symptoms, whereas the atypical antipsychotics are the newer ones and those treat both positive and negative. So let's go back to the DSM-5 criteria. So we got the first one. The second criteria says that significant functional impairment in one or more areas. So these symptoms essentially are causing significant dysfunction, and it can't just be in one setting. So it can't just be, say, at work. It has to be, like at work and at home, or at work and in social situations or something like that. The next one is the timeline. So schizophrenia would be continuous symptoms for at least 6 months. But like we said, schizophreniform is 1 to 6 months, and then brief psychotic disorder is less than 1 month. The next criteria is you want to rule out schizoaffective disorder, which we'll talk about next. The next one is it's not attributable to substance use or medical illness. And then they must have significant delusions or hallucinations if there's autism disorder. So if they also have autism disorder, then one of their symptoms has to be significant delusions or hallucinations, or else the symptoms they're having are probably just due to autism. When we're talking about risk factors for schizophrenia, the typical onset is kind of bimodal. So either it will onset around age 25 to 30 or after the age of 40. Some possible causes include genetics, stress, advanced maternal age, and social causation. What is the treatment for schizophrenia? Basically, the treatment for schizophrenia is the same as what it was for delusional disorder. So you have your cognitive behavioral therapy, your humanistic or expressive therapy. Again, typical and atypical psychotics. Like I said, the typicals only cover the positive symptoms, such as the delusions, hallucinations, whereas atypical antipsychotics like your aripiprazole or your risperidone, things like that, control the positive and negative symptoms. Mood stabilizers can also be used, antidepressants, anxiolytics, and omega-3 fatty acids, depending on the other symptoms that are involved. If a patient has treatment-resistant schizophrenia, they're still having a lot of symptoms despite all these other medication trials, you can use clozapine, which is an atypical antipsychotic. However, it does cause a granulocytosis, and I believe 1 to 2% of patients, which is kind of a significant amount because that's a side effect that can kill you. So basically a CBC has to be done weekly if a patient is on this medication. So that's something you really have to keep in mind. Clozapine causes a granulocytosis. That's always asked. Let's talk about just a couple notes that I have here. So olanzapine specifically, which is an atypical antipsychotic, works by blocking serotonin and dopamine receptors, and it is available as oral, wafer, and as an intramuscular injection. So all of the atypicals work by blocking the serotonin and dopamine receptors, whereas the typicals mainly just block the dopamine receptors. That's how they're a little different. For as far as adverse effects of the second generation antipsychotic, they can cause metabolic syndrome, weight gain, dyslipidemia, and diabetes. So you want to monitor the weight, blood pressure, lipid profile, fasting glucose, and waist circumference of these patients that are on these medications, because they can affect the body. And there is one severe adverse effect that is more common in the typical antipsychotics versus atypical, but can be caused by both, and that is neuroleptic malignant syndrome. And this is a patient will present with confusion, altered mental status, muscular rigidity, fever, elevated CK, and dysautonomia, and this can be caused as a severe adverse reaction to these medications. So that is something you have to look out for, and you want to stop that medication immediately if a patient presents like this. So I touched on this before, but now lastly we have schizoaffective disorder. And this is essentially schizophrenia with a major mood disturbance as well. So it's basically a patient has schizophrenia and major depressive disorder, or a patient has schizophrenia and mania. So that is the difference between schizoaffective and schizophrenia. So this typically onsets in late teens to early 20s and has similar risk factors to that of schizophrenia. Again, the DSM-5 criteria is basically the same, except for there's also the presence of that major mood disorder as well. So in addition to those hallucinations, delusions, flat affect, things like that, there's also a major mood disorder. Basically, some symptoms you might see are dysphoria, depersonalization, derealization, anxiety, and phobias. They can have cognitive deficits and lack of insight as well. But again, the treatment for this is exactly the same as schizophrenia. So you've got your antipsychotics, mood stabilizers, antidepressants, and anxiolytics, as well as your CBT, cognitive behavioral therapy. Just a little note on the brain involvement in schizophrenia. The auditory hallucinations that can be present in schizophrenia are associated with a smaller sized temporal lobe. So those are the psychotic disorders. Again, they all really run together. It's just understanding what the differences are, and that's kind of the key for that. So let's go ahead and move on to some disorders that kind of occur within developmental stages. So you'll see these starting in younger kids. So the first one we're going to do is ADHD, or attention deficit hyperactivity disorder. And the definition of this is a common chronic pervasive neurodevelopmental disorder characterized by developmentally inappropriate levels of hyperactivity, impulsivity, and inattention that adversely affect behavioral, emotional, cognitive, academic, occupational, and social functions. Basically, these symptoms you're going to see here are two different kind of groups. You've got your inattentive symptoms and your hyperactive symptoms. So patients can have either only inattentive symptoms, only hyperactive, or they can have both. So some inattentive symptoms include lack of attention to detail, difficulty completing tasks and organization, difficulty listening, trouble with sustained mental effort. They're forgetful, easily distracted. Hyperactive symptoms can include fidgeting, not able to sit still, running around, climbing on things, difficulty with quiet play, they're blurting out answers in school, or they're excessively talking in school and interrupting. So those are some of the common symptoms you'll see. The DSM-5 criteria basically deal with the timing of these symptoms. So basically the symptoms and or behaviors have persisted for greater than 6 months in more than 2 settings. So again, like we talked about earlier, these symptoms have to occur in more than 2 settings. So if a child is just acting out at school but is really good at home and everywhere else, then it can't be classified as ADHD. But if they're having these behaviors in more than 2 settings, then it can. And as far as symptoms, they negatively impact daily life, and they have to have more than 6 symptoms if they're less than 17 years old. They have to have more than 5 symptoms if they're less than 17 years old. So more than 6 symptoms, they have to have quite a bit of these symptoms, but a lot of them kind of run together. What you might see on a physical exam is a child fidgeting, they can't sit still, they have loud interruptive speech. They might have mild dysdiadochokinesia, which is basically they have difficulty with touching their finger to nose movement on physical exam, or the rapid alternating movements. Also might have difficulty with certain tasks such as finger tapping, skipping, tracing a maze, or cutting paper. Who does this occur in? Typically, symptoms start before the age of 12. This can be genetics, low socioeconomic status, or malnutrition, One thing that comes up all the time is ADHD is seen a lot in kids with oppositional defiant disorder or conduct disorder. So when you see a patient that maybe is described as what you think is oppositional defiant disorder and they're asking about another mental illness that commonly occurs, it's ADHD all the time. I've had so many questions about that. So it's definitely something to keep in mind. So what is the treatment for ADHD? The first line treatment would be a stimulant such as methylphenidate, Ritalin, Adderall, medications such as that. And adverse effects of this medication can be insomnia, loss of appetite, anxiety, headache, abdominal pain, nausea, vomiting, weight loss, jitteriness, tachycardia, hypertension, arrhythmias. So remember, just think of what does a stimulant do. It's like caffeine. Caffeine's a mild stimulant, so everything that you can think that caffeine might do to you, these medications can do to you because they're stronger than caffeine. Second line treatment can be medications such as guanfacine, which is an alpha-2 agonist and basically has, less side effect profile but also less efficacy. Just to note on before starting a patient on methylphenidate, you want to complete a cardiac evaluation, measure baseline height, weight, blood pressure, and heart rate because of the symptoms of potential hypertension, especially in kids. You want to make sure you have that baseline before starting this medication. Now we'll move on to the next developmental condition, and this is autism spectrum disorder. So this is basically a spectrum of pervasive developmental disorders characterized by various degrees of impaired social interaction and communication and repetitive stereotyped patterns of behavior. Symptoms for this condition, onset before the age of 3. So this is something you'll notice in kids really young. Happens more in males than females and can be caused due to genetics, but they're not entirely sure of the exact cause of autism. DSM-5 criteria for diagnosis. The first one is persistent deficits in social communication and interaction. The second one is restrictive, repetitive patterns of behavior, interests, or activities. Symptoms must be present in early development, like I said, before the age of 3. Symptoms must cause significant clinical impairment, and symptoms are not better explained by another diagnosis. So what are these symptoms that we're going to really see in these kids, especially before the age of 3? So they're going to enjoy aloneness. They're going to prefer playing alone. They're going to be hypersensitive to touch, so they don't like cuddling. They don't like the way clothes feel on them. They need a sameness every day, so they need kind of a routine. They have really good memory skills. They'll have restrictive and repetitive behaviors, lack of imagination, excellent attention to detail, and overly concrete and literal. So an example that my psychiatrist preceptor gave me is basically in a kid that has blocks. The normal developmental kid will start building a house or pretending the block is a car and stuff like that. Whereas a kid with autism might line up the blocks in order and make like a square. So much less imaginative, if that makes sense. So on physical exam, you're going to see delayed speech milestones. So you won't really see single words by 16 months. You'll see repetitive language. They'll have absent or delayed response when speaking to others. They'll have reduced awareness of personal boundaries, lack of eye contact and facial expressions, and also a large head circumference. This is asked quite a bit too, so keep in mind that's just kind of like a random one, but they do have 25% of kids with autism do have a larger head circumference. The treatment for autism is you want to start early with a multidisciplinary approach. The type of therapy that is preferred for kids with autism is called ABA therapy, or applied behavioral analysis. Some medications that can be used include stimulants and alpha agonists. They can have SSRIs if they have comorbid depression or anxiety, alpha agonists such as clonidine or guanfacine, and also The atypical antipsychotics such as risperidone can be used in severe psychotic symptoms associated with autism, but the therapy and the early intervention is the main things you want to focus on for autism. So, like I said, the increased head circumference is also related to an increased total brain volume in kids with autism. So that's just something you want to make sure you keep in the back of your mind. So now the next two we're going to go through are conduct disorder and oppositional defiant disorder. So these again are also pretty similar, so you want to remember them based on the difference between them. So basically, the main difference is that conduct disorder presents with more violence and aggression than oppositional defiant disorder. But we'll go through conduct disorder first. So this is a repetitive and persistent pattern of behavior that occurs in which basic rights of others or age-appropriate societal norms or rules are violated. Like we said before, ADHD is a common comorbidity in kids with conduct disorder. Symptoms of this occur before the age of 15 and can be due to poor home environment, low socioeconomic status, poor parenting, or neurodevelopmental factors. The DSM-5 criteria states that they have to have at least 3 symptoms in the past 12 months in the following categories. So either aggression towards people or animals, destruction of property, deceitfulness or theft, or a serious violation of rules. So what does this look like? This basically looks like a kid who is a bully, a kid who's always getting in fights, who uses weapons, who's threatening people, who's stealing things, physically cruel to people or animals, breaking laws or rules, running away from home, skipping school. They have a lack of remorse or guilt for the things that they do, and lack of concern for others. So, like I said, the conduct disorder presents more with aggression, so you're going to see the kid that's getting in fights, and the kid who's hurting animals, and that kind of thing is more conduct disorder. So what do we do for this? The number one first line treatment is cognitive behavioral therapy and parent management therapy. So you want to work with not only the kid who is having these symptoms, but also the parents. Again, methylphenidate can be used to treat ADHD, which is a very common comorbid in this condition, as well as antipsychotics such as risperidone to lessen aggression in severe cases. Also, lithium or valproic acid, those are the mood stabilizers. They can also be used to treat the aggression associated with this disorder. A lot of kids with this disorder will also go on to develop antisocial personality disorder, which is a disorder we'll talk about when we go to the personality disorders. So lastly, for this section, we're going to talk about oppositional defiant disorder, which we basically touched on before, but the definition is an ongoing pattern of angry, irritable mood, argumentative, defiant behavior, or vindictiveness directed towards authority figures that is not developmentally appropriate, lasts more than 6 months, and leads to impairment in social, academic, or occupational functioning for a child or adolescents. So, like we said, the behavior has to be happening for at least 6 months with at least 4 or more symptoms from any of these following categories. So, the first one is angry or irritable mood. The second is argumentative or defiant. And third is vindictiveness. So let's kind of break these down. So the angry or irritable mood, basically they're losing their temper a lot, they're easily annoyed, or they're often angry. As far as argumentative or defiant, means that they're often arguing with authority, they're defying or refusing to comply with requests from authority, they're deliberately annoying others, they're blaming others for their own mistakes or their misbehavior. And then the vindictiveness is just they're spiteful or vindictive at least twice. So again, this is similar to conduct disorder, but less of the aggression and violence and more of just defying authority. Symptoms for this typically will present before the age of 8, occurs in males more than females, has similar risk factors to that of conduct disorder, such as family history of crime or aggression, or prenatal substance abuse or complications. They could have head injuries or learning disabilities, poor upbringing. And the treatment here is the cognitive behavioral therapy and parent management therapy as well. So similar to conduct disorder, but less medications are typically used in this. It's more so focused on the therapy, the cognitive behavioral, and the parent management.